In the introductory talk on macular holes, we introduced the 4 stages of macular holes. In this session, we'll concentrate on macular hole stages 0 and 1 and spend some time discussing the natural history of these stages. As a review, there are 2 different classification systems that are in general use. The oldest is the Gass classification. He based his classification on the clinical appearance of the fovea because this was before the era of the OCT. The newer international classification system is based on OCT findings. The international system was published in December 2013 and added a new stage, stage 0. This stage is what we call vitreomacular adhesion. This stage is based on the OCT findings where the vitreous is still attached to the fovea, but there is a parafoveal bursa. There is no intraretinal pathology, and this is almost an incidental finding. There may be no clinical findings or perhaps just a decreased foveal reflex. Vitreomacular adhesion can be defined as a partial parafoveal detachment of the vitreous. In this case, the vitreous is still attached at the fovea. While the foveal depression is a bit flattened, the internal structures of the retina are normal. Vitreomacular adhesion is usually an incidental finding, and it usually can be ignored. However, the exception is if the fellow eye has a macular hole, and this finding may have a predictive quality for that eye. Vitreomacular traction is a bit more severe than the adhesion because vitreomacular traction suggests there are intraretinal changes. In stage 1, Gass described only the clinical change of a yellow fovea, and he predicted the changes would be at the level of the photoreceptor. Now, he also described stages 1A and 1B based on whether the fovea was yellow or if there's a yellow circle. He did not predict any inner retinal cysts. The international classification is based on the OCT, but it did not distinguish between inner cysts and outer retinal changes. When you see, examine, and diagnose a patient with a full-thickness macular hole in one eye, the question that they have either verbally asked or in the back of their mind is, well, what about the other eye? Pre-OCT data relied on the clinical examination. If clinically foveal cysts were present, then 30% of these patients would develop a macular hole in that second eye. If Gass's stages 1A or 1B were noted, and these are the yellow fovea, then the vision was a better predictor of development of a full thickness hole rather than the finding of the yellow fovea. For the stage 1B, if the vision is better than 20/40, there's a 30% risk, and that does match if you can see a clinical cyst. If the vision was less than 20/40, then the risk doubled to 66%. And I'll just put in a short word here on the stage 2 small or eccentric macular holes, and 70% will progress to a 500 micron stage 3 hole within a year. Presently, we use the OCT as a more reliable predictor. In 2004, Chan and Duker found that for the eyes with macular holes, the fellow eye had a normal OCT 70% of the time. And of those, only 6% developed a macular hole in the fellow eye after 4 years. If what they had was what they described as an abnormal OCT, then half of those did develop a macular hole. Troy in Retina 2020 defined that a little bit better. On the initial OCT of the fellow eye, if there was a complete PVD, then 0 of 32 patients developed a macular hole. Vitreomacular adhesion without pathology was 10%, and vitreomacular traction with either inner or outer foveal cysts was again at about the 32% rate of developing a macular hole in the fellow eye. The cystic spots were further developed by Lynchorn et al. In the BMC Ophthalmology 2021. And they found that inner cysts had a 33% chance of getting the second eye, but if there were outer retinal defects, and this would correspond to gases 1B, then 47% of fellow eyes would develop a macular hole, and there's a very high specificity to this finding. The earliest clinical signs of a macular hole can be just a decreased foveal reflex. This may be secondary to a flattened foveal depression, as we saw in the first case, or that can be an interlayer cyst, which is very difficult to see clinically. If the patient has a yellow reflex, the patient most likely has an outer layer defect. Just for the record, here is a yellow foveal reflex. As I mentioned in one other of my chats, you can get a yellow reflex from central serous, from a drusen, or even an early macular hole. The OCT is the way to distinguish all of those. And again, here's the diagram from Gass's Atlas and an old OCT showing the vitreomacular traction and the dehiscence of the photoreceptors. Here is an example of a stage 1B according to the Gass classification. The white arrows point to the yellow ring around the darker fovea. The OCT shows flattening of the foveal depression and the dehiscence of the photoreceptors as Dr. Gass hypothesized. This would be a stage 1 on the international classification, just as the first two examples. However, you can see very clearly that the retinal defect now is anterior and not in the outer layers. This is a 54-year-old female who had a decreased foveal reflex, and you can see the inner cyst. The outer layers, the photoreceptor layer, is absolutely normal. The cysts do not always have to be so prominent as on the last case. You can see here that the arrow points to the vitreomacular traction, and there are some very small inner layer retinal cysts. This again would be stage 1 or an impending macular hole in the international classification. This is another example of a stage 1 or impending macular hole according to the international classification. This is a 64-year-old female, vision of 2200 in the right eye and 20/60 in the left eye. The 2200 vision in the right eye is secondary to a long-standing macular hole. Clinically, you can see some irregular foveal changes in the left eye. Clinically and on the vision chart, her vision has been stable for 4 years. This is her OCT. You can see very well that there is a dehiscence or a change or a hyporeflective area in the outer retina. There's also somewhat of a flattening of the foveal depression as well. The natural history of vitreomacular traction and a stage 1 macular hole is that about half of these will resolve on their own. However, if the fellow eye has a macular hole, this is highly predictive that this will go on to a full thickness hole. So, if the fellow eye has a hole, you may want to consider some surgical intervention in this case and not watch conservatively. Contrary, if the other eye is normal, then you can watch these conservatively every 4 to 6 months and see how they do. Well, how do you know that the patient has had this particular problem? Here's an example of a patient with vitreomacular traction and a stage 1 macular hole in the left eye. You can see the parafoveal bursa and the traction on the fovea and an internal cyst. If you look at the right eye, there is a posterior vitreous detachment. But you also, if you look closely at the foveal depression, it is not normal. The bottom is flat and the right side does not match the left side. So my conclusion is that this patient had had a similar picture in the right eye before. However, when the vitreous lifted away, it left this abnormal foveal reflex. Now, sometimes patients will give you a history of some abnormal vision and other times not. This is a 51-year-old female who initially sought clearance for cataract surgery. The cataract surgeon sent this patient off for a second opinion, and the first doctor said that there were some signs of macular degeneration. She wanted another opinion, sought out a second physician who noted, quote, something else is wrong with the retina, unquote, but did not give a specific diagnosis. She had been complaining of blurred vision in the right eye that was rapidly declining over only several months, and she was having difficulty reading and seeing street signs while driving. Also, in her own words, missing letters in the middle of words. When I saw her, she was about 20/40 in that eye, 20/20 in the left eye. The top OCT is a blow-up of when she first saw me, and you can see a break in the ellipsoid zone. 10 months later, the symptoms were gone, her vision was 20/20, and you can see that the ellipsoid zone was intact. I took much care making sure that these were the same raster lines at the acute visit and at the 10-month visit. So, in summary, stage 0 vitreomacular adhesion is almost a normal finding. Stage 1 has a variable clinical appearance of either a yellow fovea or a yellow ring around the fovea. The OCT has variable findings. There can be inner cysts or a hyporeflective area in the outer retina. Half of the time, the stage 1 macular hole will resolve, and you can end up with either a normal-looking OCT, an abnormal foveal depression, or there can be some long-term hyporeflective areas in the outer retina. And if that is the case, patients will have slightly abnormal vision and describe a very subtle central scotoma.